back to talk to you guys about drugs to treat glaucoma. It's really early in the morning here, which is why you're not looking at me, because I look way too scary right now. However, we can still carry on with the audio, and the two mechanisms of action that I discussed at the end of our introduction video to this unit were in reference to glaucoma, is to, one, increase the outflow of aqueous humor at the canal of Schlemm. That means essentially drain it better. And the other is to decrease the formation of aqueous humor at the ciliary body. So the first, I'm going to break it down into categories. These are probably in the order of most frequent use, not the way we're going to talk about them, because I'm going to follow your book, even though I'd rather do it in a different order. The prostaglandin analogues, those are currently the drugs of choice. The autonomic agents, remember we said in the previous slide that a lot of autonomic drugs are going to be used here, which makes sense because the autonomic nervous system is in control of both the ciliary body and the pupil, or pardon me, the iris, and then subsequently the pupil. The autonomic drugs are the beta blockers. Those are used the most common. And then we have the non-selective sympathomimetics. So those are drugs that are sympathetic agonists, but they're not selective in terms of their receptor. Then we have the alpha-2 adrenergic agonist. There's an alpha-2 receptor actually in the eye. We haven't talked a lot about alpha-2 receptors. And then the cholinergic agonists, we're going to talk about those first. And then we have the carbonic anhydrase inhibitors and the osmotic diuretics. For the most part, all of the drugs we're going to talk about today are going to be administered topically. Occasionally, they use some of these same classes of drugs orally, but for the most part, topical drugs are, so some sort of eye drop solution is going to be used for most people with glaucoma. And then, of course, for very severe glaucoma, we might have to go another route, an oral administration. Okay, so I'm breaking it down kind of in terms of categories. So the first category we're going to talk about, because it follows the book, are drugs that constrict the pupil. Drugs that constrict the pupil are often also referred to as miotics. And the reason why constricting the pupil is helpful potentially in glaucoma is because constricting the pupil essentially pulls the iris away from the drainage at the canal of Schlemm. So it facilitates drainage. So the first ones we're going to look at are the cholinergic agonists. So cholinergic agonists are going to constrict the pupil. Remember, that's a parasympathetic effect. So drugs that actively constrict the pupil are called, that produce what we refer to as meiosis, which is constriction of the pupil. And these drugs also cause contraction of the ciliary muscle. So essentially what's happening is we're physically stretching the trabecular meshwork to allow a better drainage at the canal of Schlemm, and thereby lowering intraocular pressure, or IOP. Of the drugs up listed, these are different types of potentials for this category. Pilocarpine, the one that's in bold, pilocarpine is the one that's used most often for glaucoma. And again, they do that as a drop. And I think I wrote that in there. Yes, and they have to be administered a lot. That's kind of why these drugs aren't that popular. Not because they don't work, but because you have to administer the drops 4 times a day. So they're going to be effective against wide-angle primary glaucoma and also against narrow angle or that closed angle. And that's not that common, but these drugs are specifically helpful in that scenario. There's not a whole lot of side effects because we're giving these locally, but you might have some local side effects. One is that is common is the spasm of the ciliary muscle, which causes blurring of far vision. That's pretty common with a lot of our drugs. Other than that, the other kind of things you would expect with a cholinergic drug, like all the sweating and motility and, diarrhea and potential airway constriction and all that. Not likely to be a problem because you're administering them topically. Although some people do talk about headache and dryness of mucosal membranes Or no, I'm sorry. No. I'm talking about the wrong drug. They talk about headache, and that's really the big one with these drugs in terms of chronic use. You know, for the most part, they're not the other side effects are not common. Just blurred vision and headache, I would say, are the big ones, and drying of the mucous membranes. Or not drying of the mucous membranes. Why do I keep wanting to tell you that? It's early in the morning. That's why. The caution at the bottom is driving at night, and that's because of the blurred vision. All right, so those are the cholinergic agonists. Now let's talk about drugs that decrease fluid formation, and this is going to be the bulk of them. So this first drug is not in your book, the prostaglandin analogues. I do not believe is in your book. These other ones are in your book. Carbonic anhydrase inhibitors, which aren't used that much, adrenergic drugs, beta blockers, which is an adrenergic drug. Timolol is probably the most commonly used one, and prior to the prostaglandin analogues, that was the drug of choice. Osmotic diuretics, not so much. All right, so this, I believe in the current textbook you have, this drug is not in there. I thought I put it in at the last revision, but I don't know. When I looked at my copy, I didn't see it. So these prostaglandin analogues, latanoprost is the prototype. There's others, but they're all prostaglandin analogues. These are now the drug of choice for glaucoma. One thing that's really nice about these drugs is they have a long duration of action, which means you don't have to give them 4 times a day, and they also have the fewest side effect. They decrease intraocular pressure because they decrease the production of aqueous humor. I already mentioned that they're almost all given as eye drops, but that's the percentage, 0.005% eye drop solution. They don't have many side effects. The big ones are maybe not super common, but if you have light eyes, we may see heightened pigmentation of the iris, and it seems to be the biggest issue if someone has like blue eyes, and they might see like brown specks or brownish, discoloration to the iris. People report having thicker and longer eyelashes. That was such a dramatic effect that they actually marketed off-label like mascara for people who didn't have glaucoma, but made out of this drug, and they call it Latisse. That was the brand name originally. I'm sure there's others now. But some of the more common side effects with the prostaglandin analogues are local irritation to the eye, stinging of the eyes, and redness. But that seems to be the biggest issue in the beginning, like the first month of use, and then it more or less goes away. And then you can see some very rare side effects, headaches, rashes, flu-like symptoms, maybe some abnormal liver function tests, but again, not a big deal with these drugs. They're very rare. All right. So those are the drugs of choice. Now we have another drug that decreases fluid formation. These are not used that much, and they're called carbonic anhydrase inhibitors. So carbonic anhydrase is an enzyme, as you know, so we're inhibiting the enzyme carbonic anhydrase. Again, these aren't used a lot. This is the enzyme that's required for the production of aqueous humor. These are not available in drops. Well, they are available in drops, but the normal use here is, especially if you're going to use them chronically, would be oral. They do have orally, they do have more side effects. And the big one is the carbonic anhydrase. We'll talk a little bit about in our renal unit, but carbonic anhydrase is an enzyme that is required for the reabsorption of sodium along with chloride or bicarbonate, depending. It's kind of like a co-transport system in the proximal tubule of the kidney. So the big side effects, the major ones with oral use of carbonic anhydrase inhibitors, we don't reabsorb as much sodium because you don't have the enzyme to do it. So it causes diuresis and potential electrolyte imbalances as a result of that. So most of the time they're taken orally. There are some drops as well of carbonic anhydrase inhibitors, but like I said, they're really not used as first-line therapy. They might be used in combination if you can't get the glaucoma under control with another drug. Another thing to note about with carbonic anhydrase inhibitors is there's a cross-sensitivity to people who are allergic to sulfa drugs. Remember we talked about those in our anti-infectives. Oh, nope, we didn't. I've talked about it because I've already recorded that lecture, but you'll talk about those sulfa drugs in the anti-infective section coming up. So those are some of the stranger side effects, neurological side effects that we might see with long-term use of carbonic anhydrase inhibitors, in addition to the diuresis that I mentioned. All right, and we don't want to give them to pregnant women. So those are carbonic anhydrase inhibitors. Okay, so now we're going to look at the adrenergic drugs. So the adrenergic drugs, and there's a couple of different ones. So these drugs are going to be useful for wide-angle primary glaucoma, also secondary glaucoma if they have some inflammation. Oftentimes what we do here is, because what we don't want to do in glaucoma, and I think I said this in our introduction lecture, is we don't want to dilate the pupil because that could potentially displace the iris enough to further minimize the drainage through the canal of Schlemm. So what they usually will do is give a pupil constrictor and then an adrenergic drug. And the adrenergic drug is going to work at the ciliary body to decrease fluid formation, aqueous humor. They're given topically, so we don't worry too much about the side effects. But again, with caution with the narrow angle glaucoma, because people with narrow angle glaucoma, we especially do not want those guys to have the pupil moving, displacing over the iris, displacing. That doesn't really work. So those drugs aren't good for those people. So we want to be careful if they have that. All right, so here we go to, now we're getting somewhere with drugs that are actually used a lot. These are the beta blockers. Prior to the prostaglandin analogues, these were the drugs of choice. And the beta blocker timolol malate is probably the most commonly prescribed. It's the prototype drug here. These drugs are going to decrease the production of aqueous humor, and they don't have a whole lot of side effects because they, again, are given topically. So we don't have to think too much about our beta blocking side effects. You can see there's beta 1 selective agents, and then there's some that are non-selective to the beta receptors, beta 1, beta 2. But again, you're giving them topically, so that's not that big of a deal. So I mentioned already they decrease fluid production. They don't change the size of the pupil, which is good because alpha receptors are the ones that are at the pupil for the adrenergic side, and the cholinergic ones, of course, are the parasympathetics. They have a pretty good duration of action in that one dose can be effective for 24 hours, similar to the prostaglandin analogues. So they're really good for wide-angle glaucoma. You know, we are giving a beta blocker to somebody, so even though you're giving them topically, there is the potential for some systemic absorption. And so if you had a patient that you knew would be a beta blocker would be contraindicated, like heart block or heart failure, you might want to think twice. And now that we have the prostaglandin analogs, those are going to be used because they don't affect any of that. So that's going to be preferred. One thing it's not on that slide about the beta blockers, but I think it's notable, is that tolerance does develop to these agents. It's about a quarter of the people who take them long term, they lose efficacy over time. So that's one thing about those drugs that's not great. But other than that, they're safe and effective, but not quite as effective and not quite as safe as the prostaglandin analogs, and therefore, the prostaglandin analogs also don't seem to show that tolerance. All right, so the very last ones here are the osmotic diuretics. Osmotic diuretics are going to be used mostly preoperatively or postoperatively if somebody's had some kind of eye surgery, or as an emergency treatment in an acute kind of a closed angle or a narrow angle attack. What these drugs do, they're osmotic diuretics, they basically have the ability to quickly reduce plasma volume, and they also are good at decreasing aqueous humor production and reducing intraocular pressure. The side effects are not on here, but the big ones are headache, dryness, fluid and electrolyte imbalance. Those are the big things. The prototype is mannitol for an osmotic diuretic. We'll talk a little more about osmotic diuretics later on. Okay, so looking now not so much for glaucoma, but potentially for drugs that we might use probably most usefully for eye exams. So if you go in and get your eye examined, I'm sure you guys have done it, and you've had to have your pupil dilated, which is horrible, right? So drugs that dilate the pupil are called mydriatics, which you can see that. So the thing about mydriatics, and if you've ever had this done, they are going to cause a lot of photophobia because you get a lot of light. You know, that there's a reason why the pupil adjusts to the light, and that's to keep the bright light from slamming into the back of your retina. And when your eye is dilated, independently of what's going on with the situation around the light, and you get light in there, it really hurts. So intense photophobia is pretty common. We also would not want to give a dilator to somebody with glaucoma, of course. So there's two kinds of agents we could use. One would be an adrenergic drug, which makes sense because we know that's a sympathetic action at the pupil, is to dilate, fight or flight, right? Wide-eyed with fear. But the other one is the anticholinergic, and they tend to hang around a little longer. So anticholinergics are used probably more commonly, again, in the drop form to dilate the eye. So here's a little slide about that. I should have had this up as I was talking. As most of it I've already mentioned. In addition to dilating the eye, sometimes they're used for situations where you want to rest the muscles around the eye. And that's mostly because people really can't see very well with the anticholinergics. Because remember, the parasympathetic nervous system is also in charge of accommodation. So they're basically like paralyzing the lens, so they can't focus on things close up. So if they've had eye surgery and you don't want them looking at the TV or reading a book or whatever, these drugs are helpful. And they also do relieve some of the pain of the inflammation that you might have with either surgical procedure or if they've got some kind of inflammatory thing going on in their eye. Again, they're given topically, so side effects we don't really worry too much about, but they're anticholinergic, as you would expect, right? Again, with real caution, if people have any kind of history of narrow angle glaucoma, you don't really want to precipitate an attack of that. So we don't want to cause their eye to dilate. And the other thing to note is the effects of these things can last for quite a long time. So we got to be cautious with people with a history of narrow, or or if you have any worry that they are at high risk for narrow angle glaucoma. All right. Now we have our adrenergic drugs here working at the eye to dilate the pupil. They're used as wide angle and secondary glaucoma, but not because of the dilation. We give them, something to block that effect. But in terms of eye exam or relieving congestion, these would be a good idea. The side effects are not problematic because they are given topically and they're shorter lived than the anticholinergic ones we just discussed. But again, you got to think a little bit about people who have, if they are high risk and you really don't want to give them an adrenergic stimulant, that would be something that you want to think about. And again, cautious with narrow angle glaucoma. Sorry. It's a tiny bit too early for me to be recording a lecture in the dark. Okay, last things I want to mention here are what if we got an inflamed eye, right? Someone's got inflammation in their eye. So there's different ways to go about this. There's anti-infectives, steroids, and ocular decongestants. So first of all, the question would be, well, why is their eye inflamed? If their eye is inflamed because they have an infection, like a bacterial infection in the eye or a viral infection of the eye, then you would want to go the route of an anti-infective. And that would also bring down the inflammation. And some anti-infectives are actually have a little bit of an anti-inflammatory component as well. So you've got all kinds of reasons why people could have infections. It could be viral, it could be fungal, it could be bacterial. You've got some things that are in combination. Neosporin is like a great topical for infection because it has bacitracin for the bacteria, it has polymyxin and neomycin, so it does bacterial, antiviral to some degree, and antifungal. So Neosporin topically is good. So, I mean, it's not so good for your eye necessarily in the form of the jelly stuff that comes out of the tube because, that's not so great to put in your eye, but in a pinch, it could work. So these are, if possible, given topically. We're going to worry about killing off commensals flora, right? We're going to talk a lot about this in the next videos coming up on antimicrobials and appropriate use of antimicrobials. So when we're giving anti-infectives, there's a good chance that we are going to wipe out lots of flora that should be there and is everywhere. And then also we increase our likelihood of resistance. I'm not going to explain that too much right now, but in a little bit you're going to get that because we're going to talk a lot about it in the introduction lecture for the anti-infectives. So steroids, sometimes people have an inflamed eye, but it's not infected. Like let's say they've had they're having a crazy allergic reaction. Like I remember one time I apparently am super allergic to something about horses. I didn't know this. So I was someplace isolated and there were horses there. And of course I was touching the horses because I'm an animal lover. And my eye got so inflamed. I've never experienced anything like it. I couldn't see. It was so inflamed. It was completely congested, red as could be, right? That could have caused an acute kind of glaucoma, right? It didn't. Luckily, it went away. But anyway, if somebody's having like a crazy inflammatory reaction that's not an infection, then a steroid would be appropriate topically, ideally. Or systemically if really bad, but not likely unless like they got like poison oak in their eye or something like that. That would be something that would warrant something along those lines. So an a steroid is a immunosuppressant, right? And it reduces inflammation. And it's great, but you want to make sure that they have an infection. You do not want to give somebody with an infection a steroid because that's just going to make that infection just go to town, right? You're going to suppress the immune system and those back microbes are going to be going like crazy. But you don't want to, if somebody has a severe inflammation in their eye, it can cause scarring, as you can imagine, and it will impair the vision. So a treatment is warranted in a severe inflammatory response of the eye. So again, allergic, severe injury like a corneal abrasion that's not infected, or so any kind of non-pus producing inflammation. Pus is always a good indicator. If there's any pussy anything coming out of the eye, like if you've ever had pink eye, you know what that experience is like. If you've ever seen anyone, if you have kids that have pink eye, there's so much pus the eye gets glued together. That would not be a good time for a steroid, right? So cautions. Infections, don't give a steroid to somebody that has an infection. That's going to cause a major decrease in resistance to the pathogen because you're suppressing the immune system. And you don't want to do this for a long time. There can be systemic side effects if you have if you're doing steroids for a long time. All right, I think that's it for this part. Oh nope, I lied. Also, in the vein of eye exams, we can use drugs called cycloplegics. Those are local anesthetics. And those cycloplegics are just going to essentially they're going to essentially numb the eye. They're going to cause a lot of blurred vision, and they're going to cause a loss of near vision because they're anesthetics, and they're also going to make it so they are not able to, their eye is going to be basically not completely out of use. But it can the local anesthetics can help with the pain, like if they've got, like a corneal abrasion again, or a scratch, or, of the cornea, or they have sutures in their eye, they've got foreign bodies, those kinds of things. Oftentimes, the type of drug that we see here is kind of like a lidocaine derivative, but as a drop. Atropine is sometimes used as a psychoplegic. I think that is it for the eye. So I hope that made some sense. Really focus primarily on glaucoma, but I wanted to introduce a couple of the other ones. So coming up next, if you're doing this in order, we're going to talk about the skin. So I will see you to talk about that later.